I hope you can see the tremendous intellectual ability, scientific insight, and frankly, courage it takes to make a change like this. So thank you, Robert. We truly appreciate it. Jan Lowery is going to speak to us next. She's going to give us a summary of the Bethesda meeting. And Jan's an extremely accomplished scientist and tremendously effective writer, so we're looking forward to what she has to say. Cindy has asked me to please ask Dr. Lahiri from UT Southwestern if you are here. We're super excited if you're here, but please meet Cindy over here if you could, so we could get you mic'd up and move things along for the next presentation. Okay, Dr. Lowery, thank you so much.
Good morning. Thank you, Tom, and thank you, Cindy, for inviting me this morning. Jan Lowery from the University of Colorado, now within the Center for Personalized Medicine. Before I start, I did just want to echo Bob's sentiment to all the cancer survivors in the room. Very compelling, certainly reminds me of the importance of the work that we all do and the work that we have yet to do. So as Dennis alluded to earlier, the National Colorectal Cancer Roundtable back in December of 2017 convened a summit, a one-day summit that was focused solely on this new issue of this emerging incidence of early onset colorectal cancer. They invited 30 or more experts in the field and stakeholders from across the country to attend this one-day event. The funding was provided by the American Cancer Society, the Colon Cancer Challenge Foundation, and the National Colorectal Cancer Research Alliance. Several objectives to the day. First of all, the objective was to review the current state of science, what we know about early onset colorectal cancer, and what we know about current practices right now that are ongoing. And with that information, identify gaps in research and knowledge gaps, and potential missed opportunities in clinical practice to both identify and manage individuals at risk for early onset colorectal cancer. With that information, we were also charged with defining what we need to know and what we need to do with this information. And my role in this, at the summit was really to help the NCCRT compile all this information from the presentations and discussions into a strategic plan moving forward that would guide activities of the NCCRT and many of their partners. So this graph is going to look a lot like the one that Dennis just presented. Let me just back up to say what I'd like to do is just sort of summarize very high level some of the key points that were raised by some of the presenters during the day and the ensuing discussions that will inform the strategic plan. The day started with a very nice presentation from Dr. Becky Siegel, sort of setting the tone, if you will, of the day, reminding us of the increases in early onset colorectal cancer that were predominantly with rectal cancers, and also noting that there was a very strong cohort effect. So this led right away to discussions about what do we know about the cause of early onset colorectal cancer. And as I said, this is really similar to what Dennis presented earlier. There's now been several studies to show that about 8% of these cancers we suspect are due to known hereditary cancer syndromes such as Lynch syndrome. Another 8% have mutations in other cancer susceptibility genes which may be causing those cancers. About 14% have a known family history, a first-degree relative with colorectal cancer. And about 15%, we think, this could be more or less, perhaps could be due to individuals who have a family history of an advanced adenoma. I think we're going to hear a little bit more about that later in the day. But important to note that more than half of these cancers really don't know what's causing them. We suspect that some of these usual suspects might have a role, things like smoking, alcohol, obesity, physical inactivity, and certain comorbidities. These certainly contribute to colorectal cancer in general and early onset colorectal cancer. But the question really remains, or the question really is, do these contribute to the increase that we're seeing? So the group then posed the question, well, if it's true that some of these risk factors, or known risk factors, are responsible for the increase, we might suspect that the prevalence of these risk factors would be changing over time, specifically in these younger cohorts. And so we know that inherited susceptibility, for example, likely not to be changing over time, right? We're not seeing a change in that. Physical activity as well remains pretty stable, certainly within this age group of under 50. Alcohol, binge drinking, as Dr. Siegel alluded to earlier, it's changing over time, but really not specific in this younger age cohort. And there's been no change in comorbidities that we would expect would increase the rates of colorectal cancer in these young adults. Smoking rates have actually decreased over time, as has aspirin use, which is a preventive factor. That's sort of an interesting target. What we know has increased in prevalence over time is obesity, diabetes, screening limited to those in the age group of 40 to 49, and processed meat consumption, which makes these plausible, at least, risk factors to look at. We also the group talked a little bit about what we know and don't know, importantly, about the molecular pathway for early onset colorectal cancer. Essentially, the pathway for the hereditary causes, namely Lynch syndrome, are pretty well known, accepted and understood. The pathway, however, for those sporadic colorectal cancers, so probably more than around 80% of those not due to known hereditary cancers, we really don't know what that molecular pathway is. Some of the possibilities discussed at the meeting were the potential to look at gene-environment interactions, and these would be both the highly penetrant genes and the lower penetrant genes with environmental interactions. And the role of epigenetics came up as well. There's some evidence that epigenetics might play an important role in the increase in colorectal cancer in young adults. So the group as a whole, with the science that was presented during the day and with the discussions, the consensus was, we need some new ideas. We need to look at new risk factors. We need new hypotheses to see what's going on. And so listed at the left are some of the exposures or risk factors that percolated throughout the day from experts in the field. The gut microbiome, I know that was mentioned earlier today. What is the role of that? Antibiotic use, birth weight. And again, these are things to keep in mind that the mindset was, what are some exposures that are novel, that are plausible, but also that make sense in terms of the cohorts that we're talking about? So things like food additives that have changed over the last several decades, vaccine use, et cetera, even sleep patterns was tossed out as a potential novel risk factor that maybe we should be looking at. In terms of genetics, the group, as I mentioned earlier, sort of discussed looking at both, not just the highly penetrant genes, but maybe focusing now on some lower penetrant genes. And again, perhaps looking at the gene and environment interactions. And again, epigenetic alterations. The timing of exposure also came up as a really important factor when doing new studies to look at the etiology of early onset colorectal cancer. So now we're starting, because of the early age of onset, looking at exposures even in utero, certainly in early childhood, adolescence, teens, and early adulthood. And it was also highlighted, the group highlighted that because of this difference in the incidence and the preponderance of the rectal cancers increasing primarily, that we, in any new study looking forward, we ought to make sure that we're sort of stratifying by cancer location, colon, and rectum. There were also several presentations describing what sort of the current state is in clinical practice in terms of preventing and managing early onset colorectal cancer. This is not going to be surprising to some of you in the room, certainly not to the survivors, but we know that identification of younger adults at risk for hereditary and familial colorectal cancer is poor. As we mentioned earlier, nearly 20% of individuals diagnosed with early onset colorectal cancer have a family history at the time of diagnosis. We heard some of those stories this morning to start our day. We also know, and Greg pointed this out too, that less than half of patients have the family history documented into their medical record. Other challenges. We know that screening adherence in younger adults is also lagging behind. These are data from national population-based surveys that show screening rates, colonoscopy within the last 10 years, the top line in purple. These are individuals age 50 or older who have a first-degree relative with colorectal cancer. We see that the rates are increasing. The screening rates are increasing, now above those that do not have a family history of colorectal cancer. But the bottom line, what we see is that it's not increasing at the same pace among individuals, that critical group, the 40 to 49-year-old group, who have a family history of colorectal cancer. Other challenges, and we heard about this earlier today, that adoption of universal tumor screening for Lynch syndrome is slow. the most recent analysis shows that about 70% of cancer centers have implemented universal testing for Lynch syndrome. About 36% of accredited hospitals and about 15% of those non-accredited community-based hospitals have implemented universal testing for Lynch syndrome. Analysis of the national cancer data show that about 43% of tumors have been tested for Lynch syndrome. And as we heard from Dr. Karlitz this morning, in Louisiana, that number is only at about 23%. We also have heard today as well that the time to diagnosis is much longer for younger adults. Symptoms are not recognized. Individuals are misdiagnosed. And this can be due to both patient factors, I think this was mentioned earlier today, not recognizing these symptoms, not wanting to share the symptoms with their providers, and also by providers who are really not connecting that colorectal cancer can actually occur in younger adults. So the summary of the presentations and the information or the discussions informed the development of a strategic plan. And the strategic plan has 3 objectives: to accelerate research to address these unanswered questions, these gaps about the etiology of colorectal cancer in young adults, and to increase adoption of evidence-based practices. So these are things that we know work, but for which adoption is rather poor. That would improve identification and management of younger adults at risk for colorectal cancer, and to facilitate early diagnosis. And importantly, to solidify commitment from engaged partners that is essential to removing this plan into action. So I apologize, I know this is a very busy slide. As I said, the strategic plan is broken into 3 different objectives. The first objective shown here is to accelerate research. I wanted to point out that we created this plan, it's going from right to left, left to right, by identifying, first of all, the priorities in terms of what is it we need to know, what is the gap, or what is it we need to do. Secondly, how are we going to do this? What are some specific strategies that we can employ to get this work done? What resources are available to us today, and what resources would we need to be able to move forward with this work? And then important in the last column, who needs to be engaged? So for the research strategies, the focus, there's 4 that were identified from the group. The first one is, what is the cause of the rising incidence of early onset colorectal cancer, which I'm going to talk about in just a minute. And then what is the natural history of the early onset colorectal cancer? Bob just described the guidelines that were changed through the American Cancer Society, through the modeling through CISNET. It was noted at the meeting that these data were based, at least the rate of progression from adenoma to carcinoma is based on data from older individuals. So having new data on younger individuals might inform new models that might inform even further changes in screening. Also, what are best practices for implementing the current recommendations for identifying and managing early onset colorectal cancer? And finally, what research is ongoing that may answer some of these questions? So to make this easier to read, I've just expanded the first priority, which is really around etiological research, just to give you an idea of the different questions that the group is throwing out. What is the role of the known risk factors for colon cancer? What is the role of the novel questions? And do these differ by site for colon, for rectal? Are there vulnerable times of exposure? Has the prevalence of these risk factors changed over time? From a molecular perspective, is early onset colorectal cancer molecularly different than colorectal cancer in older adults? And if so, what does this tell us about causation? And what is the role of epigenetics? In terms of strategies, how can we do this work? The study design that percolated to the top was to conduct a prospective case control study that could be embedded perhaps in a large existing cohort or a new cohort, or within a large healthcare system that had access to a large EMR data and perhaps a cancer registry, or to conduct retrospective case control studies. Important thing to do maybe first off was to convene a group of investigators, including epidemiologists and others, to design a study and write a proposal. In terms of resources, the group identified several existing cohorts that might be used to do this type of research, some of which are cancer-specific, others that are not, such as the Nurses' Health Study and the Physician Study. Childhood cohorts linked with cancer registries was also brought up as an important resource as well. Of course, to do this work, we would need new funding and access to EHR data from healthcare systems. In terms of who needs to be engaged, of course, academic partners to do the research, commitment from integrated healthcare systems that would provide access to their patient data, EMRs, and registry data. The Center for Microbiome Research was noted as well, given the interest in looking at the microbiome as a potential novel risk factor, and of course, funding agencies. For the second objective, to increase adoption of evidence-based practices to identify and manage persons at risk. Again, I know this is a busy slide, but I want to note that the approach was really broken down into provider-level approaches, patient-level, and system-level approaches. The provider-level approaches over at the left at the top are centered around improving the provider education around the reality of the rising incidence of colorectal cancer in young adults, to start the signs and symptoms for their patients, and to separate out screening versus diagnostic recommendations for colonoscopy. I will point out that one of the key strategies identified for this priority is what Dennis talked about earlier, is disseminating the family history pool that was developed through the National Colorectal Cancer Roundtable. Physicians also play a key role in referring their patients for screening, and so the second priority for providers is to improve screening adherence in the young, so to educate them on the new guidelines, for example, and also on the importance of family history for informing even earlier screening in some of their patients. Patient-level approaches, sort of a broader approach, is to improve population awareness about the importance of family history as a risk factor of colorectal cancer, the recommendations for screening based on this history, and the risk and symptoms of early onset colorectal cancer. This will take a different strategy, such as more population-based, such as media campaigns, social media, perhaps development of new apps, so forth. From a systems level approach, really two key priorities. One really relevant to this panel is to improve collection and use of family history, collecting both colorectal cancer and polyps, information on polyps in primary care in younger adults, to inform screening and refer for risk assessment. As we heard earlier, this is something that's been tried. We need new novel ways to approach this. We've been working on this for quite some time, and I think we just need some new ideas of how we're actually going to make that happen. And then the second priority for systems is to increase universal testing for Lynch syndrome. So just quickly, the third objective, again, is to solidify commitment from engaged partners. Key approaches would be for the NCCRT, again, to provide a forum to maintain discussions around this topic, perhaps publish a collaborative paper with key stakeholders across the country. Importantly, to engage healthcare systems. This was seen as a common theme, that we need to engage systems, as they're going to be really critical in implementing many of the strategies. And then also convening the leadership of some of the professional societies that might be, for example, setting, pardon me, not setting strategies, but setting guidelines moving forward in this work. I just wanted to bring up, again, and I've sort of combined all of the different groups that in that last column who needs to be involved, and I've compiled them all on this slide. A lot of folks need to be involved to do this work. I would say many, if not all, of these are represented in the audience today. Just really quickly, we did identify, understanding some of these strategies will take a little bit longer time. There are some short-term goals that the plan can achieve. One is to conduct a landscape on the ongoing research, who's doing what now, or what is planned in the near future. Convene a group of investigators to start talking about how do we study this, what does the study design look like, what are the resources for this. I did want to note that I know that Fight CRC, another advocacy group, had a meeting in Denver. I think Heather Hampel's going to be talking about that later today, to start these conversations going and pulling together the right people and the right resources to start this work. In terms of adoption of evidence-based practices, promotion and adoption of the guidelines, dissemination of the toolkit, what Bob and Dennis talked about earlier today, are really critical and ongoing. Some of that work has already begun. Creating new messages for providers and patients, again, to sort of increase awareness about the reality that this is happening. It does happen in young adults, and to identify champions with professional organizations. In terms of partner engagement, the paper, really, I think we hope that by publishing this paper, and it's now under review, this would serve as a conduit, a way to sort of disseminate this to others, to other partners, to engage them in this process. And the other role that we could do, this NCCRT, is to support ongoing efforts of advocacy groups, all of which is aimed at keeping the dialogue going. So with that, I will say thank you. Tom.